mortality data among British troops in 1855 and accomplished significant reduction in mortality through organizational and hygiene practice, patient safety element. She is also credited with creating the world's first performance of hospital in 1859. So this is most of the quality professionals will know the statistics, but being a nurse, I am a bit proud to say that it was a nurse who was a pioneer for all this quality improvement which started. Culture concerns the values, beliefs, and assumptions that staff infer through story, myth, and socialization, and the behavior they observe that promotes success. Or it's simply that what you would do when nobody is watching. So that is only a real culture. What if nobody is watching what we are doing is who we are. About Lucien Leap, I want to tell about something about Lucien Leap. Lucien Leap is a physician and a professor at Harvard School of Public Health who was being active in trying to improve the medical system and to reduce medical error. In 1994, he had an article, Error in Medicine, published in JAMA, which called for the application of system theory to prevent medical errors. So according to Lucien Leap, what he says is mistakes are caused by bad systems and not bad people. Systems set people fail and fall into a trap. We must recognize that humans are error prone and try to error proof our system. Remove hazard wherever possible. People need to believe that errors are never all their fault. Safety is all about future and not the past. So this yesterday, sir spoke about the doctor, anesthetist. He had spoken about the different kinds, levels of maturity of the safety culture among the organization. So pathological, there are certain institutions still pathological. Why waste time on safety? So they see all this quality improvement activities is waste of time and waste investing into quality into professionals too. So these are pathological institutions. And we do something when we have an incident that are reactive and bureaucratic. We have a system in place to manage all the identified risk, but all that is in only paper. And proactive, we are always on the alert for risk that might emerge. That is being proactive. Risk management is an integral part of everything what we do that is generated. So these are the different types of organization. And coming into now nursing as a key to improving quality. Nurses represent the largest segment of caregivers in healthcare system. Today, my topic is mostly on the nurses' role in building that safety culture in the organization. And that's why I would like to highlight the role of a nurse. And I being a nurse, I would like to highlight this more. So nurses represent the largest segment, okay? Even in any organization, any hospital you go, the highest number of healthcare worker would be a nurse. And nurses spend around 31 to 44% of their time in direct patient care activities. Nurse experience an average of 8.4 interruptions to a failure of work system per 8-hour shift. This is all from the US data. Medications, orders, supplies, staffing, equipment. And nurses spend around 42 minutes of their shift solving the operational failures. Nurses are often the patient advocate and safeguard the patient from harm. Patient safety is the cornerstone of the high quality healthcare. So this is the nurse's role in quality. If you see what is her role, okay, she's a collaborator. She has to collaborate with all the allied health professionals, the doctor, patient relatives. You see, only a nurse is there all 24/7 with the patient, though in different shifts. And they are the center point. Nurses are the center point, either a doctor or a pulmonologist or a physiotherapist or a dietitian, anyone who comes to the ward or a clinical area to know about the patient. It's the first contact of person is a nurse. So collaborator and educator. Educator is educating the peers, sometimes educating the interns, educating the allied health staff too. Okay, and advocate for the patient. And manager who manages the entire unit, sometimes at the unit level and sometimes at the organizational level. And care provider, bedside care provider too, and a leader, one who leads, and researcher. All these fits into a nurse's role as an RN. Now coming to now patient safety first. So this is from one of the NHS slides. 1 in 10 are harmed when receiving care in the hospital of WHO and USA. Okay. And 1 in 18 hospital stay in Canada results in preventable harm or death. So up to 13% of people in Canada receiving home care experience an harmful incident. Falls, medication, and behavior incidents are top 3 health problems. What incidents occur in your area? So these are US statistics. And if you see organizational culture, culture is the way we do things around here. Shared values, beliefs that interact with system structure to produce behavioral norms. It depends on which part of even India, okay? In which part, whether we are in US, we are in Gulf, we are in India. So I have experience working in India as well as in Gulf, and I have US friends. So the way how the behavior, value system, belief system of our colleagues also matter. How they look at us matter. Hidden curriculum, normal day-to-day practice in your work unit that often undermines formal education and organizational policy. So the reputed institution that is CMCH Vellore, where I got my nursing degree, and even in 96, 97, 98, we had the openness. We can ask our doctors questions like, why do you do that? And never even we called them doctor. This was not our culture in CMCH Vellore. We call them by name. But when I came to this Bahrain, I see like, no, we have to address doctors as doctors. They do not like us to call them by their name, and they feel like, no, it's not, that respect is not there when we call them by even by name. So the culture difference, you see, the behavior, how they are brought up. So it was a Christian institution. We were taught that we have to voice when it is needed. And that kind of a freedom, it was inbuilt, that value, belief and all that, it was inculcated even in 1990s. But even in 2022, we don't have that kind of a culture, even in some developed countries, which we assume. So this culture is very, very important, and that is inculcated from the society where we come from. Okay. Patient safety culture, now let us talk to. An integrated pattern of individual and organizational behavior based upon shared beliefs and values that continuously seeks to minimize patient harm that may result from care delivery processes. In healthcare settings where there is a safety culture, the provider, staff, administrator, patient and families are all engaged and encouraged, supported to make care safer. How many times we allow our patients? See, when I talk about this healthcare, where I was from, like, where I was empowered, but in the same country where India, where I studied, where how many times I have seen, like, patients empowered to speak. When empowering the patients to speak, I feel Gulf is 100 times better, because here patient questions the healthcare worker. They have the right to question. But in our country, if you see, like in India, especially in villages or where the healthcare provision is given for free, how many of us or how many of the healthcare workers allow the patients to question them? So when they are in the receiving end, we do not empower them. That is the state of some hospitals in our own country. Okay. Next is component of patient safety culture. So that is like, just culture is the base. That is how it has to be. And then there is reporting culture, flexible culture, learning culture, and informed culture. So base of all this is the just culture. And if you see about the just culture, fairly balancing and understanding of system failure with professional accountability. Okay. And I'll play a short video now. Before that, let me complete this slide. Emphasis on quality and safety over blame and fault finding. People believe they can question existing practice, express concern, and admit mistake without ridicule or punishment. Errors do not result in automatic discipline. Instead, try and determine root causes and the system breakdowns. Do not personalize or do not make one person accountable of whatever that has happened. It is the system problem. You can see one side is punitive. You needn't to be punitive, and either be like a blame free. Whatever mistake happens, it happens, and then we cannot keep cool too. Okay, we have to have a balance that you will see in the future slides. Just I'll play a short video, then we will continue with this slide.
I was on a surgical team when I noticed a doctor making a critical error. He was preparing to operate on the wrong side of a patient. Now, we have a surgical safety checklist that we follow, and in this case, we noticed the permit didn't match what the doctor was doing. So we tried to stop the surgeon, but he said the permit was wrong, even though it had been verified by the now sleeping patient. We couldn't even get support from the supervisor or the anesthesiologist. So in the end, the surgery went forward. As nurses, we felt awful because there was no support from management to stop this doctor. I mean, what's the point of having a checklist when it's not even followed? We felt absolutely powerless to be an advocate for this patient.
Now, let us go to the next slide. So just a culture. So over discipline, what it happens. So in the previous video, you have seen that how a nurse in US expresses, like, no, she's been given, she's not allowed even to speak. So, but then I do not know if you have to take a video in India, how many videos we have to produce and release. But then over discipline. So one thing I noticed among the nursing, especially the nursing team and the hierarchy, what we say is like being strict is the best. So that was being even taught even when I was a nurse, as a student nurse. So being strict is not something very good. Like it's not necessary you have to be very strict. We should allow our student nurses or even our staff to speak up. Okay. So if you over discipline, if you say like too strict, what happens? So what happens is individually we are getting disciplined, that's fine. But then what happened? The system error is getting covered. Okay. If you do a medication mistake, I remember going to nursing superintendent and writing a statement, and then we are given a warning letter. All that now I feel like no, it shouldn't have happened. It's like no, after learning so much or being in the having the journey of patient safety and infection control professional for this many years, I found that as a student nurse, whatever I learned or certain things which was taught to me was not right. Okay, so individually when we discipline, what we get, what we do, we decrease reporting. We are not going to speak up anymore. And if we are not going to speak up anymore, what happens? There is decreased learning that is happening because we are not going to share our lessons. There are two ways of learning. One is you make your own mistake and then you learn. And otherwise, you learn from somebody else's mistake. That somebody else's mistake, we learn that opportunity is gone. Okay, decreased learning and less opportunity to improve system. And next is because of this, ongoing error, same error happens again and again and again and again. And eventually the patient is harmed. So this is the effect if you're going to over discipline in our system. Next is what is just culture then? Okay, so just culture is managing behaviors. Okay, so we are going to see the analyze the behavior into three. Okay, is it a real human error? Like no, maybe the professional who was maybe a doctor or a nurse or a physiotherapist, whomever it can be, maybe he did not choose that behavior. It so happened. And next is the at-risk behavior. At-risk behavior is we choose to do that. We are choosing to do shortcuts, like not doing a fault risk assessment or not having a close monitoring of a patient whom we are thinking like no might dip. So what happens? This is at-risk behavior, and then we are thinking like nothing will happen. Okay, 10 times I did not do that and nothing happened. Maybe the 11th time, if I do not do that also, if I do that shortcut also, nothing will happen. We assume and then we do not foresee the risk. And what happens? In that case, we are supposed to be coached, like no, the importance of risk assessment, why we are supposed to monitor, why this early warning scores are very important to identify the early deterioration in patient. So if that there are after finding the root causes, all that root cause can be analyzed and then that can be taught to us. And next is reckless behavior. Reckless behavior is like, for example, having some kind of a narcotic or drunk and coming for work. So we are choosing that behavior. Or if we are going to do a night duty whole day, we are not going to sleep. And then we are choosing that behavior. So whole day, if we do not sleep, we know for sure that we won't be able to concentrate in our work, or we will be very sleepy while caring for the patient. So this is, we are choosing the behavior and we know the risk. So if we do this, this is called as a reckless behavior and that requires a discipline. So this is what in just culture, this is how the behaviors are managed. Now, this is one of the JCI slide. You can see what are the root causes. They have identified the root causes. Okay, you can see human factor, communication, leadership, assessment, information management, physical environment, care planning, continuity of care, medication use, operative care. All these were the root causes. And this is from one of the NHS slide, and they did a survey, and even in NHS, this was the feeling of the healthcare worker. When they did the survey, this is what they found. Okay, the 3 red flags. Staff worry that making a serious error would lead to disciplinary action from management. Okay, so the patient safety, which is at heights in NHS also, this is a kind of a feeling the healthcare worker have over there, and how much it would be in our own country. Staff feel that making a serious error would limit career opportunities around there. Staff feel that making a serious error may cause the staff member to lose or her job. So overall perception of patient safety at unit level have improved since 2012. That is, at the unit level, it got improved, but they say that at the organizational level, it had declined. Now, who are the key contributors for this patient safety culture? It's leadership. It starts with the board members. Leadership, board commitment, and ongoing visibility. Priority of safety versus production and efficiency. Okay, we are seeing the output. How many patients are being seen? How much revenue? How much is the profit? So if instead of seeing in that way, like how many people safe care have we given? So this is the priority over the safety. Organizational resources and rewards for patient safety. Yesterday also, sir had shown that the people are rewarded. Similar thing happens in our organization too. We reward, we conduct that as a big event, and then all that in PSF, if you take, that is one of the patient safety website, where for educating patients, speak up, ask me 3, the 5 points which we have to remember while you're coming for a visit, OPD visit, about the medication safety. All this we educate them, and this our staff create as a small videos, banners, slogans, and all that. And this is put in our Instagram website. So this was few years ago, in 2016 it happened. And so we are also planning to have more. So this way, this is also one sort of encouraging for staff who are performing well in patient safety. And family and patient engagement, effectiveness and openness of teamwork and communication, openness of all team members, including patients and families, in reporting incidents and problems when they occur, and organizational learning. So instead of telling that this person did this mistake, instead of that, this occurred without naming and shaming, this occurred and similar incident can also happen in your area, and be careful, and then we need to be taking some proactive action. So what we can do? Speak up. We have to encourage our staff to speak up, be a safety advocate to the patients, speak openly during the incident investigation, report incidents, share ideas on improving safety, bring patient and families to conversation. Promote and support incident reporting management. This is very, very important when it comes to a safety culture. Familiarize yourself, in your own organization, how this risk management works. Any incident will always have a connection towards, or it should be linked with your risk management system. So today you found out, one of the high alert drugs is being not properly stored means, or there is a chance that there an error can happen, or maybe there is an error happened. Okay, in one place, if this error had happened, then other 10 places in your own organization, there is a chance. So put that in your risk management, and then see that you clear or standardize the process across the organization. Okay, that is how this risk management, really a proper risk management, helps you to take proactive action in other area of the hospital. Encourage incident reporting, provide rewards and recognition, review incident reporting data to identify key incidents and share with your team. Sir has taught about Pareto chart to us. So what are the top 5? At least that one you emphasize to the staff and take that proactive action and standardize the process. Complete multidisciplinary, including patient and family incident investigation, follow up in a timely way, ensure timely feedback on incidents and lesson learned shared, ensure understanding of the disclosure process and policy. Actually, there is a disclosure. If you just go and Google, you will find a lot of material NHS has got about this disclosure process and policy, and there are a lot of videos and PowerPoints on disclosure. This is one important element. So all that patient want is to know that what happened to him, not that like, no, if there is an incident, then we will give them a big money discount and say that, okay, it's okay, keep cool. It's not like that. Not every patient is thinking like money would be the solution for their problem. They wanted that this similar incident doesn't happen to any other patient. Okay, so, and they are being recognized that they are in pain, and then some action we take to calm them down and then make them like, to come out of that incident. And this not only for the patient. Okay, this open disclosure is not only addressing the patient, also the staff who is involved in that particular incident. So this, if we haven't initiated in any of your organization, please do initiate that. This disclosure process is a very, very important key point, and this is also the requirement of most of the accreditation standards. Now, create opportunities for your team to talk openly and share safety concerns. Add safety as a standing agenda item for meetings. Share experience with incidents during huddles. So, in our organization, we daily have like huddles. Morning huddle will happen. Then weekly huddle with the leadership. Then morning unit huddles. Huddle is one way where the management can meet their staff at the ground level. Maximum it takes 5 minutes to 10 minutes. There is no like formal no seating arrangement, and all that is not there in any corridor. Just all the leaders and managers, we meet together, and then we'll say like, no, these are the key things that is happening in the institution, or what had happened yesterday, or what any decision. So we don't wait for one formal meeting to have a folder to sit and discuss with our management. This is very informal. In the morning huddles, we ask like, no, this is the current problem, what is the solution, and we get the solution then and there, and guidance we get, and then we proceed further. So this huddle, if you haven't started in any of your institution, please do start. This is one place where the leadership can meet with the ground level staff. Use safety cross or calendars to track the measures of safety. Assign the team member to be a safety leader or champion. So this is, we call it as like, no, we have safety link staff as well as infection control link staff, patient safety link staff, QPS link staff. So these link staff are going to be your advocates. So we are very few in quality, but we have this link staff abundant. Like, no, we have around 20 link staff in infection control alone. So, and also for patient safety and QPS, we have link staff, which includes doctors as well as allied health staff and nurses. They are across the organization. So anything we wanted to communicate, if we just text them in our group, this link staff group, this message of safety is being spread throughout the organization. So this is one way that where you can reach out, the leadership can reach out, or your team leaders can reach out to your staff on a daily basis too. And whenever there is something you have to share, you can share. Join or lead leadership walkabouts to discuss safety. This also happens for us. Leadership daily they meet. Apart from that, to meet the staff at the ground level, they go on a weekly basis or sometimes monthly basis. So there also staff directly, the front line, even right from security to the receptionist to the cashier, they can talk to the leader directly. There is no hierarchy of getting an appointment and meeting. It happens in the corridor. Hold straight talk about the quality and safety sessions. Carry out team briefing and debriefing. Use a learning board to capture safety concerns. Lead, promote, and support initiatives to improve safety. These are the important things which we can do to promote safety. Next is promote a just culture and create an understanding of what it means. Incorporate patient safety education into all staff orientation and ongoing training. Share patient and provider stories. So yesterday we had one doctor was, or one staff, one audience was asking like how we can, the new doctors who are coming like, for a short while, like, they are not contract staff and they just come and do their work for a short period of time. So these staff also have to be addressed. The orientation goes to them. All the policy and procedures also they have to abide by. And the staff orientation, the first 1 week they are there. They've been fully educated and they have a complete orientation paper, which includes every point of what in the healthcare organization, quality and patient safety and infection control they need to know. And after they finish their checklist, that comes like, once they have finished all this, only then they are authorized to work full swing in our organization. So this is one way to capture them right from the time when they join our organization. Share the patient and provider stories. That is one way. Okay. And before I could show this video, so this video, once I play, like, let us have a short discussion. I haven't seen this kind of discussion in our meeting so far, but this is a sensitive video where we all can contribute and we can do some difference in our own healthcare organization when we go back tomorrow. So next, because the main topic for me today is for nursing. And so that's why I wanted to, I have this 2 slides, but I have respect and I have a lot of respect for all the other healthcare professionals too. So, but then when I have to talk about nursing, the nursing profession must produce leaders from the bedside to boardroom. Okay, that is high time now. And whatever I'm showing, these 2 slides are from US statistics, and I can understand how it will be in India. But if we haven't started, so please start empowering the nurses. Nurses must see themselves as leaders. Leadership that involves working with others as full partner with mutual respect and collaboration is needed and has been associated with improved teamwork and patient outcomes, cost saving and reduction in medical errors, increased job satisfaction and retention among nurses. And if you see the underrepresented on institution and the hospital boards, again, this is US statistics, recent survey have found that nurses are underrepresented. In hospital and healthcare system, only 0.8% of the voting board member in institution and hospitals were chief nursing officers, compared with 5.1% who were vice presidents for medical affairs. And in community health system, only 2.3% of nurses occupied seats on institution and hospital boards, compared with 22.61% were physicians. So whomever nurses are in the audience, so nurses should be prepared to lead the change to advance the health. Okay, so thank you for patiently listening, and it's not yet over. We will see a short video, and after that we will have a short discussion.
2 young children, Victoria and Adam, and this is the story of the death of my wife, Elaine, who died in March 2005 as a result of an attempted routine operation that went wrong. There's some confusion about the precise time, but we know that 6 to 8 minutes in, a number of things were happening. The anaesthetist had already started to attempt to intubate Elaine. The oxygenation was still at 40% or lower. The heart rate was falling. The ENT surgeon waiting to perform the op came into the theatre. An anaesthetist from an adjoining theatre became aware of a commotion, and he walked in to see what could be done. And at least 3 nurses answered a call for help. And what happened is that the 3 consultants continued with the attempts to intubate, and they used a variety of different techniques and a variety of different pieces of equipment. The nurses, meanwhile, performed some tasks under their own initiative. But what we can say is that 10 minutes in, with hindsight, this is a situation of can't intubate, can't ventilate. This is a recognised emergency in anaesthesia for which guidelines exist. We're now 10 minutes into this attempted procedure. The patient, my wife, is blue. Her oxygenation is 40% or lower, and it has been for 6 minutes. The anaesthetist has 16 years experience, and he is regarded as diligent by his colleagues. The ENT surgeon has over 30 years experience. The other anaesthetist has additional skills pertaining to difficult airways, and 3 of the 4 nurses are all experienced in their job. And it's perhaps worth just wondering at this stage what was going through their mind. The intubation attempts had failed, the oxygenation was very low. What we know actually happened is this point in, 10 minutes for a further 15 minutes, the 3 consultants would appear to have continued with their attempts to intubate to the exclusion of any other option. And that at the end of that 15 minutes, we're now 25 minutes into the whole procedure, they eventually get Elaine's oxygenation to 90%, but she's actually been at 40% or lower for a total now for 20 minutes.
Keep going. Can we get above 90?
No, she won't go up.
No, you got 90 though, that's better.
I don't think we should carry on with the operation.
No, I agree, I think we should abandon it at this stage.
Okay.
The airway itself is not secure though, And so they fiddle around a bit more, and in fact her oxygenation falls again below 90% for a further 10 minutes. And finally, by the time we're 35 minutes in, they seem to make the decision that the best thing is just to let her wake up naturally.
Let's wheel her back, quick as we can.
And they transfer her to the recovery room. She lays there for an hour and a half, and of course, she never wakes up. Based on the evidence from the inquest and from Professor Harmer's report, the lead anaesthetist, if I can call him that, in his own words, lost control. There was a question mark in the inquest about who people felt was in charge at different points. There was certainly a loss of awareness, an awareness of time, but also an awareness of the seriousness of the situation. If you like, the awareness of what was happening wasn't shared by each of the consultants. There was certainly a breakdown in the decision-making processes, and it would appear that the communication processes dried up amongst the consultants. The story with the nurses is very different. The nurses were generally aware of what was happening and what needed to happen. When I said to you that 6 to 8 minutes in, those 3 nurses arrived, one of them asked her colleague to go and fetch the tracheostomy set. There was already a quick trachea kit in theatre. She went out, she collected the tracheostomy set, she came back in and she announced to the consultants that the tracheostomy set was available. And there was no response. One of the other nurses who walked in immediately saw Elaine's colour, immediately saw the vital signs, and walked out again to phone intensive care. She phoned to check that a bed was immediately available. She came back in and she announced to the 3 consultants that a bed was available in intensive care. And in her own words, they looked at her as if to say, "What's wrong? You're overreacting." She actually walked out and cancelled that bed. At the inquest, 2 of the 4 nurses stated that they knew exactly what needed to happen, but again, to quote from the inquest, didn't know how to broach the subject.
So this is a short video. I know it's a quite sensitive video, and maybe this video is a little biased towards nurses. Even nurses do mistakes. I don't say like all the time nurses are perfect too. But what is quite obvious here is the nurse is having the hesitation to voice out loud when there are experienced doctors around. Like we feel timid, like no, we are just nurses and what we can do. And this patient, if the tracheostomy would have been put on the same time and this nurse pulled over the trolley, this patient would have been saved. So this is just one scenario that is but the real scenario. But there are several scenarios in our own organization. So, sir, over to Dr. Tennarasu, sir. So, doctor, you can initiate discussion on this, and so you can create some awareness. After this video, there will be so many suggestions, sir. So you can read through. Yeah.
Yes, ma'am. Thank you. Thank you so much for your presentations.
Yes.
Yes. So I have some questions from your practice.
Yes, sir.
Question number 1. As per your presentation statistics,
Yeah.
there is some numerical fact like 1 in 10 harm as per WHO report.
Yeah.
So this is from America, correct? What about, is there any statistic? Is there any statistics from our place, from India, or even from Gulf? Is there any similar statistics from India or even from Gulf?
Definitely, it would be with the same ratio only, sir. Maybe there it is reported, but here it is not reported. That's all is the difference. There they are at least making statistics and releasing it.
If you compare India versus Gulf and US,
Yes, sir.
is there any significant difference in the culture?
I find being an Indian and living in India, there.
No, this is not to blame some country. This is to know the real fact. You know,
Yeah, the
for
real
patient
fact
safety,
is, sir.
first we should accept our mistake.
Correct, sir.
Correct.
Feel shy,
This is
sir.
not to blame Gulf or US or India. No, this is to know the real fact. So, what do you think? Is there any significant, as a nurse, what is your opinion regarding culture? Is there any significant
been in,
difference in culture?
Yes, sir. Definitely, there is a significance here. Like in the Western countries, I've seen my friends, like, no, they have they are given that psychological safety, because there are a lot of patient safety going on, and they have given the psychological safety to open, like, no, they can speak up. But that speak up, I don't think, like, no, in all the parts of India it is there. At least in CMCH, well, where I was trained, there was. Definitely there was. I wouldn't say no. There was. And even in the hospital where I work, we have to speak up and we are encouraged to speak up. But I have my own friends who are working in India and some remote hospitals. Definitely there is no, like, no, they feel timid and shy to talk and speak up in front of great legends like, no, doctors and consultants. We do feel shy, to be honest. Yeah.
Okay. What about from Bahrain regarding culture?
This is what, sir, like, no, here people from various countries come to work. So this is their home country, and the doctors, how they behave in India, the same way do not behave here. Because I've seen extreme, like, no, the pride and the respect which they demand in India, that kind they are not definitely in Gulf, because we all are workers. We all have come together, so we need to survive here. So to be honest, they are very humble and they adapt to change. And whatever is being told to them, they adapt easily, and they are willful to change. Anything changes, immediately they will adapt through. This is what my experience in Gulf. Two different hospitals I work with, and in American Mission Hospital also I am working right now. They change, immediately change, and whatever is being told to them, they immediately adapt.
Excellent. Excellent. And as per your presentation,
Yes, sir.
there is culture in the unit level, correct? But
Definitely, sir. Definitely.
but organization wide there is no culture. Why it was like this? What is the
This was
main cause for this problem?
This I feel the leadership, sir. The leadership. Leadership. They have to, like, no, be a role model, and they have to, when the patient incidents are reported, they have to be, like, no, taking action in, like, no, as a system oriented and not individual based. So once one staff is being disciplined or some action is being taken, the others very, very scared. That incident is enough for them. Like, they will not finish. Like, one action taken on one staff has got impact on whole organization. So the organizational level, definitely it's fully, based on this leadership and board members and the management.
So as a quality professional, is it possible to blame leadership for this issue?
Sir, leadership, depending on, see, like, how we are led, that's how the staff are. We are just followers. So if the leader is going to have a vision of quality and patient safety, and if they're going to, no, so the first thing which I suggest to our management also is, first to enroll the managers and the leaders into the course. IHA has got so many courses and very little fee, nominal fee, and if you have bulk enrollment, you will get it for very less price. So first, around 100 leaders in our organization were enrolled. Even in 2010, 12 and all, we started, like, around 100 people together we were enrolled, and then we all study that. We were all made to study. So every unit supervisor, like, no, charge nurses, the service, the doctors, everyone were trained. So then everyone now sees the same way. So if everyone is in the same way, then the culture development. So education is very, very important, sir, in this aspect. So even so many people who are in the audience, if they're leaders, please enroll all your staff whom you feel like, no, that change has to come. And that is the change. What is AMH is all about now is because of the education, the leadership vision. Because of that, now we have a good culture in our organization.
Excellent, excellent. From quality, from your side, whether you're providing any education, special education for your leadership,
Leader, that's what, sir.
is there any continuous education from quality department, not from IHA or from some other
Okay.
international practice?
Yeah.
From your side,
100%.
is there
Yeah.
any standard continuous
So
education?
from as soon as the employee comes, like we call
Yeah,
it.
this is orientation. Orientation we can do for all.
Okay. So after orientation, what happens?
Which include all
Correct.
area, all domains, not only quality. Correct?
After orientation, we have certain mandatory lectures, which is on incident reporting and complaint management. Then open disclosure is mandatory for us, like we educate. And then after, like our leader, as I told you, our leader is a visionary leader and he's passionate about quality. Every month, the CCEO itself will come and give one topic on to all the staff. Like recently we had this high level organization, HROs, how it should be and how staff is supposed to be. And apart from this, we have our incidents, the learning lessons, which we share also with the department wise, organization wise. We don't use the names, but then we say like, no, this is what we found and this is how we have to grow up. So, and I told you, like morning huddles, we have got this managers who will come. So morning huddles, unit huddles, like whatever happens, any incident, like even if it is handful, the learning lesson is immediately shared. It is kept in a shared folder. We have intranet. We call it as intranet, where all our organization staff can access. And so we keep it over there. And this staff see that, like, they know, like this particular incident has happened here. And so we all have to be very careful. So we learn from others' mistake. And then now, after so many years of inculcating safety in our organization, now nobody finds it like very odd, like if they do a mistake, because they know like okay, this is, we are reporting just to learn, we are learning out of it. So that mindset people have come, sir. But did this overnight? It happened over years. He joined in 2009 and now we are in 2022. There is a big transformation in our organization, in our mindset. But this was all the good leadership only, it happened.
Good. Yes, ma'am. And well, it seems there is significant, there is excellent culture in your organization.
Yes, sir.
Thanks for your continuous initiative. Whether you are sharing to other organizations, sometime as a quality professional, if there is some good practice from our organization, we should share to other organizations also. Sometimes we can publish as a research article. Correct?
Yes, sir.
What are the challenges we faced over the period of 10 years? What are the initiatives we did for this positive culture? So probably if you write some article and if you share to other organizations, probably we can able to culture among the people, correct? Not only in the organization, correct?
Sure, sir. That we have to initiate. That we are not doing so far. Definitely we need to do that.
Because now, as per NHQ vision, quality not only for organization, quality is mandatory for the whole country, even for the public. Correct?
They cannot go and complain. They cannot reach hospital.
Am I correct, Jansi ma'am?
Yes, sir. 100%, sir. 100%.
Now we need to do something for the whole community, not only for our organization. Correct?
Sir, that's what, sir, we are following footprints, sir, because I know you have that vision of like creating something new. I mean, creating some quality and patient safety.
Yes, ma'am. Yes, ma'am.
We are helping you.
Try to share your practice to our people.
Sure, sir. Sure, sir.
Please. Okay. Thank you. Thank you so much. Any other questions from others, please? Any questions from others, please?
I want to ask a question, sir.
Yes, sir. Please.
Hello.
Yes, sir.
Yes,
sir. I am Dr. Jasper Neja.
Yes, sir.
Very nice presentation. The
Thank
nurses must be encouraged. I have 2 more points here. Number 1 is the effect of nurses in healthcare organizations. We've been seeing that satisfied in the hospital itself because the management, the quality of services provided by the organization and the paramedical staff and the patients and the relatives, they don't give that much respect to the nurses. So nurses are not satisfied with the administration itself. So there should be some level of this, some standard should be there, which should show that how much level the nurses are satisfied here. So the nurses will join the center which have a higher satisfactory standards. So other healthcare organizations will also compete for the same, and they will give respect to the nurses. Number one. Number two, satisfaction of the patient. Patients are more satisfied by the nurses as compared to the doctors, because they have to wait time, or they are not satisfied with the paramedical staff also. So this should be, I mean, channelized openly, that patients are very satisfied with the nurses. This will encourage patients to give respect to the nurses, and the nurses to develop a better friendly relation with the patients and the relatives. So these points are very important. And as mentioned by Sir also, leadership is very important. Beside this, nurses should be trained in the communication skills also, because with the communication skills, they can train the paramedical staff, they can train the doctors, and they can train the administrative staff also. In fact, nurses are the pivots on which the whole healthcare organization stands and rotates. So
True,
the
sir.
nurses should develop the communication skills also. Thank you very much. This is wanted to try. Thank you.
Thank you, sir. Thank you. Yes. Jansi ma'am,
Yes, sir.
regarding nurses' practice, is there any competency problem from our nurses? Because still there is no involvement in the operations. So is there any, whether all the nurses are aware about the quality and patient safety and operations? Why still there is no integration between the nursing practice and administrations? Why they are not coming to the administrations?
Sir, actually, in our organization, actually, we are there in our GCEO, that is Group Chief Operating Officer, is a nurse, sir, by basically. So she was a nurse basically, and then in our organization, that's what already we are there in the board. So in leadership committee, we are there. So we have been called for meetings on a monthly basis in the form quality improvement meeting and environmental care meeting. So safety meeting. So we are called. So, but then this doesn't happen in India probably, like, no, this is because first of all, leadership should empower nurses. Like, no, they should encourage them. You can do it. And then you give respect. So the moment you give respect for us, all the allied health will know that, okay, management is giving respect. So we should also give them respect. So when we are respected, then automatically what happens, like, no, we are able to speak up. We are able to speak up all that roles we are able to give. So the respect of patients will give if the allied health is going to give. Allied health will give if leadership is giving us. So you understand that we are also competent and capable, and how in Western countries, like, there are nurse practitioners. How the nurses are, in Canada, the first level patient can approach is only a nurse. If the nurse finishes her treatment, only then the doctor appointment is being given. So nurse practitioners are so many there in India. In community health nursing only, I see this kind of nurse practitioners where we are allowed to give a certain amount of some vitamins and medicines and some vaccines and all that. But there should be a curriculum for us to be a nurse practitioner even in India also. So, like, we have to first be recognized by our own people, sir. Then if we are recognized by our own leadership, we are educated, like, no, we are given education, we are sent for higher studies. So only then, like, no, this development will happen, and then the feeling of, like, no, we can also do it will get. And then there are so many now nursing CEOs. One of my classmates is a COO, Chief Operating Officer, in one of the US hospitals. So like this, it will happen only then if the leadership identify us and empower us. It cannot happen overnight. So there should be a big transformation, and there should be a trust factor from the leadership towards the nurses. And you will see a different healthcare system if nurses are empowered, because we are the center point for every professional reaching the patient. We are the center point. If we are empowered, then the whole, like, no, family of healthcare is empowered, and you will see the difference in the quality and patient safety.
Exactly, ma'am. Thank you, ma'am. Thank you so much.
Thank you so much, sir, for giving me.
Any other questions from others, please?
Sir, I have a question.
Yes, sir. Please go ahead.
Yeah, sir, there were 3 consultants, and the level of oxygen was going below 40. So there must be some obstruction in the airway, because of which nurses felt that tracheostomy has to be done. So these 3 consultants, how come they didn't realize that the level of oxygen is going down, and the patient is sinking. After a certain time, when the level of oxygen increased, they left the patient for some time so that she can come back. That's what they're saying. And then probably they will operate the patient. So during this time, why they didn't feel like something needs to be done and the patient is left on its own, saying that, I mean, it's like either they were overconfident or they were totally ignorant, or I don't understand what exactly was going at the back of their mind. Whereas nurses were quite active and they understood the situation very well. So why it is so?
May I answer to it?
Yeah, please, sir. Please, doctor. Yeah.
So myself is an anesthetist. So on viewing this video, the main reason is ego. To be honest, see, it is not due to the obstruction in airway. It is mainly due to difficulty in intubating that patient. Sometimes, no, we anticipate difficult airway and we keep things ready. Sometimes unanticipated difficult airway can occur, where if an anesthetist is not able to intubate, we immediately tend to call another anesthetist. Sometimes the ego occurs. They feel that it is inferior to call the help, and they try to manipulate the airway and keep on trying to intubate. But during that time, the saturation falls. So, as you said, it is mainly due to that superiority complex and ego. That is the main thing. So, to be frank, if you are in any crisis situation, you should not feel any inferior in calling for help from your juniors also. So that is the moral of this video actually. Teamwork
Because so this I asked this question. The reason being, when I read certain books on laws also, they say the law has got a tendency to change the behavior of people. As we are talking of creating procedures and lot of other things which will act as a like a stepping stone to improve upon the process, but actually this ego factor and this training, so how can we going to deal with this, because it is going to be with the people all the time, and it can't be corrected. Is it not possible to for the people to come out of this zone?
Unseen behavior.
That is what I showed yesterday in my slides, how that training occurs in an aviation when compared to healthcare industry. Training, that is how your situational awareness, what is the decision making, especially in crisis, is very important. That training we are not giving actually. So that
because there was no sense of urgency, there was no sense of integrity, and they were trying to do something and that they were not able to figure out. So that 10 minutes of crucial time is lost.
No, the golden.
And then the patient was left on his own for her to come back when she was not actually in a position, I feel.
Yeah, these are all preventable medical errors.
Errors.
Yeah.
Right. Understood. Thank you. Thank you, sir.
Thank you, Dr. Jayachandran, sir.
Thank you.
Any other questions from others, please?
Hello, madam. Hello.
Yes, sir. Yes, sir. Please.
Hello, ma'am. As myself, Venkatesh here. So, like, as from, I think you are from a quality background, ma'am.
Yes, sir. Yes, sir.
Ma'am, I just want to know, like, since we be having a monthly, patient safety rounds and all. So, is there any? Would you like to put any kind of focus in this, such that like we can have some kind of a checklist or kind of anything like
excellent
we can have
question,
which we can have an, because when we do on a patient safety rounds where all the department like 4 or 5 departments, it will definitely include it. It will include the medical doctor, nurses, operations manager, HIC, quality, everyone will include. So such that if they have a crucial rounds in their, not only on day-to-day basis. So I think this rectification of this patient safety and related to, patient safety, we can, I think we can have a improvement in that.
Excellent question, sir. Yeah. So what we are doing in American Mission Hospital is like, to be honest, past 2 years, I was fully with infection control as part of patient safety with all the COVID cases. Now, it's like little light. So what I have done is WHO has released now on 2020 patient safety self-assessment. Like you can self-assess your own organization, and on the 5 criteria basis, patient safety safety points are being captured in that. So what you do, you do analysis. You take that checklist or around 145 criteria are there, and you can even mark what level your hospital is. Like no, they're telling you how you can run your own hospital to reach out the management. This is an excellent tool for you right from.
Madam, your voice is a little bit breaking in between. I don't know. Like, is my problem or?
Okay, sir. Now are you able to hear clearly, sir?
Yeah, ma'am. Yeah.
So patient safety self-assessment WHO has released in the year 2020. Use that particular tool, do a gap analysis of your own organization. This is what right now I'm doing now. And after you do the gap analysis, do the risk rating and what is your top risks. You go and show this to your management. This is your top risk and you have to close this. This has got head to foot, all the patient safety aspects of an organization, any hospital could have. And it is achievable. It's not like, no, it's not achievable. That kind of a very tough checklist. It's not so. It is very big, which an organization should have. So this is what right now I'm doing in AMH in my hospital now. And that checklist will cover for you from top leadership to ground level and all aspects of patient safety, including patients and allied health staff and everyone in the organization will be covered. In fact, they give you what questions you have to question them during interview, what you have to environmentally, what you have to observe, what documents you have to look in for, what questions you have to ask for, everything you name it, you have it there. So this will be my recommendation for you, sir. WHO, World Health Organization's Patient Safety Self-Assessment 2020 release.
Sure, ma'am, definitely. Madam, how at the same time, madam, what do you can you put your focus into the diagnostics, where we can do a HERA kind of a thing?
You're saying during your rounds, you mean to say?
Yes. At the time of
that's what I tell you. This safety, you have environmental safety and you have clinical safety. So
yes, ma'am.
5 components. What I said was first was leadership, and the second was this clinical. Okay, I'm not the clinical aspect. The clinical aspect means pressure ulcer, PVT, fall risk assessment, clinical early warning scope,
These are all
deterioration.
clinical,
Yes,
deterioration,
your S bar.
S bar, Ma'am, S bar has come for doctors also, right?
100%. 100%. Every healthcare organization, every staff should be taught on S bar. That is very, very important.
It's been practicing for JCI also, as per JCI?
100%, sir. JCI should definitely have this as one of the component.
Okay,
for NHRA component, I'm very sure we have this ISBAR as very important component. And environmental means compressed gas cylinder, laser, nitrogen, liquid nitrogen, which you have, and electricity safety, equipment safety. You name it, everything is there in that tool. So that is right now the tool which I'm using to do gap analysis in mine. And we have completed that. Now I'm speaking with my leadership to close the gaps. So similarly, in your organization, now you have authoritatively one document which is being recognized worldwide. So definitely your leadership will not say no to you.
Okay,
so
ma'am.
This is a good tool.
Okay, ma'am. How about in the lab and radiology, ma'am?
Lab also, sir, they're saying about this TLT badges and whether there is radiation leak in your own units. Radiation safety is one component. You should have a radiation safety officer. How often this TLT badge is checked, and constantly exposing themselves in our country, in Bahrain, we have to have the SCBC done also. So different countries requirement that, and then lab in which level of your biological safety level, which you are. So depending on that, the criteria will change. So infection control also will guide you on that. And that for that infection control, lab safety, biological safety level 2, 3, like this, you go search in CDC, you will get for infection control point of view. And patient safety, they're talking about transport of specimens, what temperature it should be, and this training for the staff of lab. Everything you have it, sir. Everything you have it.
Okay, ma'am. Yeah.
You go read that book. Yeah.
Thank you.
Yes,
thank you, Jansi ma'am. Thank you so much,
thank you,
sir. Yeah.
Thank you so much. Sir.
Thank you all.
Thank you for giving this opportunity, sir. Thank you, sir.
Thank you, ma'am. Thank you. Welcome. Thank you all. Good night.